So hey guys, so today I'll be continuing from the series I started, which is pain. I'll continue from my introduction. Last time I was talking about pain, the introductory part. I defined pain. I told you the basic things you know about pain, the classifications of pain, the little things you know about pain, right? So today I'll basically focus on the mechanism of pain, right? I will tell you how pain is felt, right? At what level pain is felt, why do we feel pain, and the role of every single part of our body in pain. I'll take this little by little, okay? It's quite a big topic. Yeah. So basically, I said last time, right, that pain is what is an unpleasant sensation, right? That is always mostly associated with our emotion. It has emotional aspects, right? Even if you might not see this mostly in textbooks because we don't really have a kind of strong basis about the emotional aspect of pain, right? And is most of the time is due to is always or most of the time associated with what a tissue damage, right? That means there must be some kind of damage or what a potential tissue damage, meaning that it either warns us of a damage that has occurred or that is about to occur. So now let's start with how do we feel pain, right? Yeah. So actually, how do we feel pain? Like, what is this pain? Like, yeah, I've defined it, but when do we start feeling pain? Actually, pain is not really separate, right? Normally, every single sensation, whatever it is, whether it is touch, temperature, pain, or what, or proprioception, or whatever, whatever message is being sent by our periphery, are sent up to our central nervous system, where this message is analyzed, right? They go as a bundle, right? Meaning that they go as since they go from right our periphery to our central nervous system, they're called afferent, right? Ascending pathway. So pain is one of these feelings, one of part of these signals that we feel. So these signals normally are being sent carried out from what? Receptors on our surfaces of our tissues, skin, mucous membranes, wherever they are. Then these signals are sent through what? Through nerves to our brain, where this message is what? Analyzed, right? And when I say analyze, what do I mean? That it is now like the brain tries to understand what kind of information is this? Is it pain? Is it touch? Is it temperature? Where is it coming from, right? But today I won't be majorly concerning on all the kind of sensation. The main one I'll be focusing today on is pain because it's really vital. Maybe in further videos I'll talk on some other kind of but today I'll be talking on pain, right? So this pain signal, right? Meaning that they have pain. If we have pain signal, meaning that we have pain receptors on the surface of the skin or wherever they are, right? So these pain receptors, they actually nerve endings, right? So this message is carried through nerve, right, to our central nervous system, where the message is what? Analyzed as pain. Then the response is sent down. So like I said earlier, um, these signals are transmitted by what? Neurons, what? Neurons and nerves to where? Our central nervous system, where what this information is analyzed and blah blah blah, right? So the key point here is what? Nerves, neurons, right? So these neurons, actually they're the functional unit of the nervous system, right? Yeah. And they'll be seeing how they do this. How do these guys carry messages from the receptors? In fact, I'll quickly run through what exactly, for better understanding, what exactly these neurons are, right? The structure of these neurons. So this neuron is what? Is an electrically excitable cell. It's a cell like every other cell in your body, right? But this form of cell is a different one, right? It's an electrically excitable cell that processes and transmits information through what? Electrical and chemical signals. Yeah. So I'll quickly run through the various types of neurons, right? So a neuron basically has three main parts. Like every cell, it has a cell body or a soma with a nucleus in the center. Three main parts: the cell body with the nucleus. It has an axon and a much thinner dendrite. So based on their structure, we have actually three main types of neurons, right? We have actually let's start with the bipolar neuron, right? A bipolar neuron has what? A single axon, what? And a dendrite. Okay, I forgot to mention. At this point where the axon comes out from the cell body, It actually has a name. It is known as what? The axon hillock. Axon hillock. It's really important. As we go further, I will tell you why this place is really important. It's very important. So I forgot to mention, an axon actually takes information to the central nervous system, to the glands, and yeah, but dendrite does more of what? Branching. I told you that neurons normally, right? Neurons don't run from one place to another. It actually if it passes information, right, to other neurons and other neurons till it gets to its destination. And actually these dendrites, they do the function of what? Collecting this information from other axons. Meaning that what? If there's another neuron here, its axon will terminate what? In this dendrite, and this information will be sent. So this is one type of neuron, the bipolar neuron, where it has what? One axon and one dendrite, right? So there's also another type of neuron known as what? The multipolar neuron or the multipolar neuron. The multipolar neuron has what? A lot of dendrites. A lot of dendrites. But still one axon. Just one axon, right? And finally, the last type of neuron is what? The pseudo-unipolar neuron. Actually, this is quite special. It's called a pseudo-unipolar, and if you did a Greek, you know that pseudo means what? False, right? A false unipolar means that it actually looks like a unipolar neuron, but in reality, it does not have one process. It starts off as what? With one process and divides into two. So in later days, people say that, right, it has a single axon and a dendrite, but you cannot call one of this a dendrite and one an axon, because first it comes out as an axon from the axon hillock and divides into two branches. So this is a branch of an axon. So it is not properly, it's not right to say axon and dendrite. So in this case, we call the one that goes to the central nervous system the central process, right? Why the one that goes to the skin peripheral, we call it what? The peripheral process. So don't make the mistake, right? So a pseudo-unipolar neuron does not have what? A dendrite. It has what? An axon, a single axon that divides into two parts. So the one that goes toward the central nervous system is called what? The central process. While the one that goes to the peripheral, like your skin and mucous gland, is called what? The peripheral process. So in reality, it has just one axon, but two processes, not one axon and one dendrite. Yeah, so that's that for that. Basically, today we'll be talking about what? We'll be talking mostly about the pseudo-unipolar neuron, because this is mainly the neuron responsible for pain, right? Pain stimulator, yeah? And I forget, of course, you all know that the main classification of neurons, we have the sensory neurons and we have the motor neurons. Sensory carries what? What? Pain, touch, the feeling, right? The stuff. While motor controls what? The muscles, right? But today we're talking about pain. Pain is a sensation, right? So we are mostly going to deal about the sensory part. And in later videos, we'll talk about the motor response and stuff. When we talk about the reflex and that kind of stuff, yeah? So guys, I said that a neuron is a cell like every other type of cell. So if a neuron is a cell, what does it tell you? It has what? A cell membrane. So we'll quickly look at the neuron now. So yeah, it's a neuronal cell. A neuronal cell covered by its cell membrane. I told you it has a nucleus, right? So it has a cell membrane covering. So guys, remember earlier in this video I said that what? A neuron is what? An electrically excitable cell. Electrically meaning that what? It what has a what? A voltage, a charge. So this membrane is really important, because between the inside and the outside of this membrane, there's a balance between charges, right? And these charges, this balance is kept by what? Membrane pumps. There are pumps that go in between these membranes that regulate the amount of charge outside the membrane and inside the membrane. So the relationship between inside and outside, the relationship between two particles, like relationship between two things, is always mostly called a gradient. So there's a kind of gradient charge, a concentration gradient of charge outside and inside the membrane, right? And these charges are provided by what? Membrane pumps and channels, right? And mostly the ion pumps and channels, mostly ions that regulate this charge is mostly sodium ion, potassium ion, and chloride ion. So in this video, actually you ask, like, why am I telling you all these things? Because these are the basics of this pathways. If you don't really understand this, you won't understand anything I'm going to say further. That's what I'm taking my time to emphasize on this. Yeah. So I'll tell you how as I go further, I'll tell you how important this axon iliac is, how important what this membrane is. Why I forgot to tell you that there's one other type of neuron known as what? The anaxonic neuron. The anaxonic neuron does not what? Have what? An axon. Anaxonic. So because they don't have an axon, they don't have what? An axon iliac. And because they don't have an axon iliac, they cannot generate what we call an action potential. So that's why I'm taking my time to explain it, so you know, so you understand the function of all these things and their importance, right? So this is the point where it gets real. This is the whole point of this lecture. So at this point, I beg you to stay glued to your chair. It's about to get real. It's about to get complex. Remember, the whole point of this lecture was to start simple and get complex, right? But I'll try my best to make it as simple as possible for you, for better understanding. So now we are going into the main part of this lecture. The pain pathways. How all this conduction system goes. At what part exactly? Where do you start feeling pain? How does your brain differentiate from a very strong pain, as you call it, or a very severe pain, and an acute pain, or a mild pain? Yeah, I'll be telling you all this. So let's start. Like I said earlier, nociception, or the feeling of pain, occurs as a result of what? The stimulation of the nociceptors. The nocireceptors, that is pain receptors. Either by what? A nauseous stimuli, a pain stimuli, or what? It can be due to what? An inflammation or disease. So I'll be telling you how all this work. So I said like pain is conducted from our periphery to our central nervous system, right? Meaning that it involves the peripheral receptors, our central nervous spinal cord and brain, right? Yeah. So underneath the skin, we have what? This sensory nerve endings, this free nerve endings, right? These receptors, nociceptors, pain receptors. Yeah. So let's see what happens now. Where exactly they are on the skin. Yeah. So in the skin, we remember that it has 3 layers from histology. It has 3 layers from even high school. We have the epidermis, dermis, and hypodermis. So now, where is this? Where are these nociceptors located? Yeah, yeah. Nociceptors actually are not found in the epidermis. They are absent in the epidermis. They are actually found where? In the dermis. Dermis. And like I said earlier, these are what? They are free nerve endings. Free nerve endings. And these guys are actually, they're actually what? Sensitive what? They are sensitive to what? Mechanical stimuli, thermal stimuli, burns, whatever, even chemical stimuli. Yeah? So what happens actually? So now when these nociceptors are stimulated, what happens? They send this message what? To the spinal cord, where the message is further sent to the brain, analyzed, and information is sent down. So now we'll take it gradually. Let's see what happens between what? The skin, the receptors in the skin, and what? The spinal cord, till the spinal cord. Yeah. So like I said, let me rub off my skin. These free nerve endings in the dermis are sensitive to different kind of stimulus, right? So when they are stimulated, for them to send a message to the central nervous system, the spinal cord, they need to be connected to a nerve fiber. And I say, what kind of nerve, what kind of neuron, what kind of nerve is found, is available for pain? The pseudounipolar neuron. And what I said, the pseudounipolar neuron has just what? An axon that divides into 2 processes. That's why it's called a pseudounipolar. It's a false unipolar, meaning that even if it has just one process, it divides into one axon, it divides into 2, giving it what? 2 processes happens. Now when these nociceptors get stimulated, let's say mechanical stimuli, let's say you get jabbed by pain, pricked by pain, what happens? These guys, they'll convert the mechanical stimuli into what? Electrical signals, electrical impulses. And these electrical impulses travels the length of the axon or this peripheral process to the cell body. To the cell body. This is the cell body of this pseudounipolar neuron, right? Yeah, and from this cell body, a central process leaves it to the spinal cord. Yeah? Yeah. So let's see how this depolarization occurs. So I told you that a nerve cell, like every other cell, has a cell membrane, right? Yeah, so this cell also has a cell membrane. So if you are to make a zoom at this portion of the cell, any cell, let's make a quick zoom. So if you to zoom this, it's going to be something like this. Guys, we have the zoom picture here of our neuron cell, our nerve cell, with its cell membrane. So guys, inside the membrane of our nerve cell, right, it is more charged negative. It is charged negative compared to the outside. On the outside is more positive, right? Positive charges. Positive charges. So in a resting cell, this is how it is charged. A normal cell is charged negative on the inside and positive on the outside. Like I told you earlier that there are three main charges that contribute. There are three main ions, right, that contribute to the maintenance of this: sodium, potassium, and chloride, right? But today we'll be talking about the most important of them, the main one of them, right? The most important of them are sodium ions. Actually, our cell membrane, first of all, does not look anything like this, right? And actually, there are spaces in between, little spaces for pumps in between. So I'm going to just go into create spaces. So like I said, the main ion that has the power to influence this charge is what? Sodium ion. We have more of sodium outside the cell membrane. That is why the cell membrane is charged positive on the outside. And we have fewer sodium ions inside. That's why it's charged negative on the inside. So what do you think happens when there's a mechanical stimuli to the nociceptor? What? It causes what? An influx of sodium ion inside the cell. So this changes the polarity of the cell. We call this depolarization. So if at this point this is when you introduce your needle, like this is where the guy was pricked, right? It causes an influx. This through the pumps here, the sodium pumps here, it causes an influx of sodium ions. So it kind of changes the charge. It changes the charge on the cell membrane, making outside now more negative than inside. So inside becomes what? Positive. And it propagates. First of all, I must be clear on this. There's a law in physiology that says that what? Subthreshold stimulus cannot cause an excitation, right? First of all, the propagation I was talking about, this propagation, depolarization propagating along the nerve, is not an action potential. So there's a law of physiology that says what? A subthreshold stimulus, that a stimulus that does not hit the threshold, cannot what? Cause an action potential, cannot cause this depolarization to go along the length of this what? Nerve process. What do I mean? Let's take for example, right? Let's say the cell was resting at what? Minus 90 millivolts. And the threshold for a generation of an action potential or an excitation or depolarization is what? Is 70 minus 70 millivolts, right? Meaning that if the stimulus that you cause, the mechanical stimulus you cause on the skin, right? If it triggers the influx of sodium ions, as long, going from minus 90 to minus 70, that's more positive charges. If sodium ions keep entering, it keeps going little by little. Once it hits the threshold of minus 70 millivolts, it activates what? An action potential is generated. An action potential. Yeah? So as long as it does not hit the threshold, which is minus 70 millivolts, an action potential cannot be generated. This is very important. That's why someone can use a pin it is very important especially in neurology, right? I'll tell you later why it's really important, right? Yeah. So when I use a pin to touch your skin, you might not feel it. But the point at which you feel it is the point where it hits threshold. So once it hits the threshold, what an action potential is generated. And this message is this action potential comes in the form of depolarization, right? So this depolarization message means that this shows that sodium is being, this graph shows that now all sodium channels are open. Sodium is now flowing inside the cell. So sodium flowing in the cell now flowing inside the cell now changes what? The polarity of the cell. That's depolarizing it, changing it from what? The normal negative inside to positive now, and propagates along the length of the whole axon. So I am clear up to that. So the next point I want to make is this. Now, in as much as we have a pseudounipolar neuron, we have types of nerve fibers also, depending on their speed and their strength. And there are two things we use to judge them. The size of the nerve varies, right? We have the big nerves, right? The big nerve fibers, the ones with the big nerve fibers, and we have the ones with the small nerve fibers. And notice, the ones that have the big nerve fibers are always very fast. They're quite faster than the ones with the smaller nerve fibers. And another thing that is used to judge the speed of conduction along this nerve, like it judges the rate at which this conduction, this depolarization moves along this whole nerve, is what they call myelination. So I mentioned two things. First of all, it was the size of the nerve or neuron. Second is what? Myelination. Say myelination. What is that? Yeah, myelination. Yeah. So normally nerve cells are protected by some specialized kind of cells. The name varies depending on where it is. In the central nervous system, these cells, nerve cells, are protected by what they call, not all nerve cells, some special nerve cells are protected by what they call oligodendrocytes in the central nervous system. But in the peripheral nervous system, we are still dealing with peripheral nervous system. We have not gotten to the spinal cord yet, right? So we are still in the peripheral nervous system. So let me quickly go back to the smaller diagram of this. So still the same diagram but in smaller form. So in the peripheral nervous system, there are some specialized cells that kind of encompass the nerve in different places, protecting it, right? These cells in the peripheral nervous system are called Schwann cells. Schwann cells. Schwann cells. I suck at drawing, right? The whole purpose of everything is for you to understand it. Okay, my drawing. I just want you to understand it, right? So these Schwann cells, they're individual cells, meaning that they have nucleus. They have their own nucleus. Right? If you look at my drawing, you find out that that these Schwann cells did not cover totally the whole length of the nerve. There are some spaces where it is not covering those spaces. Now, listen very carefully. Now, this is why nerves with this myelin. So, okay, now these Schwann cells, right? Collectively, they're called a myelin sheet. A kind of fatty streak that kind of protects and insulates the nerve, right? So, you say insulate. Why would it insulate? I'll tell you why now. So, collectively, they're known as what? Myelin sheet, right? Yeah. So, these guys don't entirely cover the whole length of the axon. Yeah? There are some spaces in between. So now this leads us to why they actually make nerves faster. I told you that nerves, that conduction during depolarization, it goes through the whole length of the axon, right? Yeah. But in these specialized kind of nerve fibers, the myelinated nerve fibers, I told you that these Schwann cells, they kind of act like an electrical insulator, meaning that this depolarization, since it's an electrical impulse, and this myelin sheet serves as what? As an electrical insulator. It means that that this electrical impulse cannot go through these places that have this myelin sheet. So does not make sense. How then does it make it faster? So what does this electrical impulse, what does it do? it skips these places where this myelin sheet is covered. So the nerve impulse, the depolarization comes like this, skips from one place to the other. It jumps. So it skips to only the places that don't have what? That are not covered by this myelin sheet. So that's what makes it faster. In a normal nerve, this impulse is supposed to travel through the whole length. But because of this myelin sheet, it does not have to travel through the whole length. It only skips. It keeps skipping. It skips because it cannot pass through this place that covered by myelin sheet. Yeah. So we call this kind of conduction system, we call it saltatory conduction. From the Latin name salter. Salter means to jump. So it jumps. So it like, does this place that is not covered by myelin sheet, does it have a name? Yeah, it has a name. It's actually called the nodes of Ranvier. That's the old name. The new name now, I think the latest name it has is neurofibrillary or something like that. Neurofibril nodes, something like that, yeah. These nodes of Ranvier. So action potential in a myelinated nerve does not have to travel through the whole axon, right? So it just jumps from one node of Ranvier. Node of Ranvier is these spaces that are not covered by myelin sheet. It jumps from one node to another node. So it makes it very fast. Unlike a normal nerve that it has to travel through, this one jumps from one node to another node. So for a nerve fiber to be very fast, I told you that speed depends on two things, right? The size and the what? And the myelination. So for a nerve fiber to be very fast, what do you think it needs to be? It needs to be what? Very big, and also what? Also what? Myelinated. So if you have a pain, if you have a sharp pain, like a burning pain, that needs to get to your brain instantly, like, you need a response. You need to when you touch something very hot, like fire, yeah, you need to withdraw your hand instantly because it can cause tissue damage instantly. So you need the message to get to your brain as quick as possible. So what kind of fibers do you want? You want a fiber that is very large and also what? Myelinated. And exactly your body provides this. That's why you have what? The A delta fibers. You have two main types. Actually, you have a lot of A fibers, but we're talking about two main types of fibers, right? Yeah. We have the A delta fibers. These ones that are responsible for carrying all those sharp pain. When you get pricked by a pin, you withdraw your hand instantly. It is carried by A delta fibers. When you get when you get burned with fire, you withdraw your hand instantly. It's called A delta fibers. Now we also have fibers that are not what? Okay. Do you after you were hurt by pain or something, like from fire or something, do you, like, after a few seconds, do you feel that achy pain, that dull pain? Now sometimes you feel pain, right? But you cannot tell exactly where it is, right? You just know that I'm feeling pain somewhere in my leg, I'm feeling pain somewhere in my hand, but I cannot tell exactly where the pain is. Like I'm feeling pain somewhere in. But you are like, where is pain? One other characteristics of these A delta fibers, this sharpness, because of their size, and they are very specific. I'll tell you why they are specific later on when we get to the central nervous system, the second part of this pathway. But you see, so there are some, so that dull achy pain is not carried. Of course, that pain that comes later after you have experienced real pain, that dull pain that comes after, is not being carried by A delta fibers. It's carried by some other type of fibers. These fibers are known as what? The C fibers. C fibers. These are just different types of the pseudounipolar neuron, right? C fibers. These C fibers, they are not myelinated, right? Meaning they don't have myelin sheet. What does that mean? What does that tell you? They cannot carry out what? Saltatory conduction. If they cannot carry out saltatory conduction, meaning that what? They can't jump. Like the nerve impulse coming cannot jump from one node to another node, right? The action potential cannot jump from one node to another node, right? Meaning that what? They have to travel through the whole length of the whole axon, right? That will make them a bit slower. So compared to their speed, I think the A delta fibers, because of their speed, they take about, they are so fast, they go about 60 meter per second, 60 to 30 meter per second. But the C fibers, because of the lack of saltated conduction, and again, their fibers are thin. They are not thick. You get, so this travel like about, I think, 0.5 meter per second, 0.5 to 1 or to 2 meter per second. You can see the difference between the speed. Yeah, yeah. So that's it. So those dull, achy pain. So mostly these safe fibers are found mostly in muscles. That's why they're not specific. They're dull. They take a lot of time to get processed. Before the message gets to the central nervous system, it takes a lot of time. I will tell you later. Okay, now later on we'll be finding out the role these C fibers, in as much as they bring dull, achy pain, right? They're not specific. Don't rule them out like they have no importance. These guys have a very good importance, right? Later I will tell you why. Why do you feel sad when you feel pain? Why do you cry when you feel pain? For those babies, they cry every single thing, yeah? Why do you fear? Why is that when you feel so much pain you can't sleep? You'll find out in as we go on. Wow. So now I'll move on to the second part of this pathway. Now you just seen the peripheral part. What happens from the receptors to where to our till we get to the spinal cord. So we'll see what happens now from the spinal cord to the brain, the upper centers. Now what happens in the central nervous system? This is the peripheral part of pain. You can see this is peripheral pain, right? But before I move on to the central pain, to the central part of our, I'm going to make some clear. So now I said, like, we have the pseudounipolar neuron, right? This peripheral process goes where? To the what? Pseudounipolar what? The cell body. Every neuron has a cell body, right? So now there's a part of the spinal cord. Yeah, we have a lot of cell bodies. Actually a lot of cell in neurology we have a lot of cell bodies. We call it a ganglion, right? Actually it takes different names. Sometimes in certain levels it can be called gray matter, it can be called nuclei, called different things. So yeah, so this is our peripheral receptors. This is peripheral receptor. This is pseudounipolar neuron. We do have cell body, obviously renal neuron. So now let me draw a typical spinal cord. Yeah. Hope my diagram is clear. Yeah. So now, what really happens when the central process of what our pseudounipolar neuron gets to the spinal cord on that same level? Yeah. Notice nerve fibers enter the spinal cord through the what? The dorsal root, right? Through the dorsal, they enter through the back. Yeah, it makes sense. Yeah. So normally in a spinal cord we have a lot of roots, nerve roots actually even like this. Something like this, which join together to form a spinal nerve, right? Yeah. So we have the anterior horn leaving remember the efferents, they leave the spinal cord through the anterior horn, the ventral root, while the afferents enter the spinal cord through the what? Dorsal root. So there's a place in this space where accumulation of this pseudounipolar cell bodies. In this dorsal root, there's a kind of bulge here in this dorsal root where a lot of cell bodies, all these cell bodies, especially this when they accumulate, this part is called what? Since this is the dorsal root, And I told you that accumulation of cell bodies, we call them ganglions, right? And since these cell bodies accumulate here in the dorsal root, so this portion is called what? A dorsal root ganglion. A ganglion is a ganglion consists of cell bodies of many nerves, but we are looking at what happens in one single nerve, right? Yeah. So let's say this is cell body, the central process of one of one of one of one pseudo unipolar neuron, of one pain nerve, right? Pain neuron, yeah. So the central process, it gets to the what? To the dorsal horn. Normally, the parts of the gray horn that call of the gray matter, we use horns to call them, right? We have the ventral horn and we have the dorsal horn. So when this central process of what? Of the pseudounipolar neuron, the pain neuron, once the central process gets to the dorsal horn, something happens. The journey of that first, I told you earlier video said, a neuron does not just run, one single neuron does not just run to the central nervous system. It gives off, like in a track race, there's track race where you have like 3 runners, where you run and you pass the baton to the next. Exactly. That's how neurons do. They pass the baton to the next neuron, right? Yeah. So we just call the first neuron, we call him simple, first order neuron, right? So the second neuron that takes the baton, we call it what? The second order neuron. Yeah. So another neuron takes the baton from here. But for it to take the baton from there, it needs a chemical signal, right? It does not just tell it to go on. You need to transmit the information, the action potential. And how do they do this? The first order neuron, at the terminal, at the end of that neuron, it passes the message to the second neuron, right? Through what? Chemical signals. And one chemical it releases is what? Glutamate. Glutamate is what? A neurotransmitter for pain. So the first order neuron, at the terminal of the first order neuron, it releases what? Glutamate. So into the space between the first order neuron and the second order neuron is called what? A synaptic cleft. Into the synaptic cleft, it reacts with what? The neuron kinase receptors on the postsynaptic neuron, on the what? The postsynaptic neuron, postsynaptic cleft or neuron on the what? The second order neuron. So once the second order neuron gets the information, what does it do? It crosses over to the other side. Crosses over to the other side and ascends upwards. In medical term, the term for this crossing over to the other side is known as what? Decussation. When it decusses, it goes to the other side and ascends what? Where? To the thalamus as the what? Spinothalamic tract. Actually, this spinothalamic tract is a name given to certain parts on the spinal cord where what? Where nerves going to the thalamus. Nerve going to the thalamus from the spinal cord, right? Where they pass in the spinal cord is called a spinothalamic tract. So I will try to make my diagram a bit smaller so I can tell you what really goes on. This goes on, yeah. So let's try to push my diagram a bit downwards. So a quick review for, I think I was too fast, so I'll quickly review it, right? So this is the peripheral receptors, the peripheral process, the cell body, which is supposed to be in the dorsal root, ganglia, cell bodies. Actually, there are millions of cell bodies, right? So this peripheral process, remember this nerve is myelinated, right? Yeah. Continues where? To the what? To the it continues where? The central process continues to the dorsal horn. Yeah? In the dorsal horn, what happens? It crosses over to the other side and ascends what? As the spinothalamic tract. So in later videos, I'll tell you why this is important. So you know, I'll after tell you the effect of drugs. So when you want to cure pain, when doctors want to give anesthetics, that's why you have how I'm going to tell you how they make their choice of anesthetics, right? Yeah. And have you noticed something that they give non-steroidal anti-inflammatory drugs to treat pain? You're like, what? Why would they give a non-steroidal anti-inflammatory drug to treat pain? I'll tell you why they do that, right? And I'll tell you it is really effective. And I'll tell you why it's really effective. I think that the central process of the pseudoineural neuron node gets to the spinal cord. In the dorsal horn, it what terminates and give up to the second order neuron, which second neuron most times what decusates. It crosses over to the other side, then ascends what upwards. Upwards where? Let's find out. So it ascends upward and goes what? Through the lateral part of the, let's say this is the brainstem. Through the lateral part of the brainstem, goes through the lateral part of the brainstem. Let's make our brainstem bigger. Let's God, I suck at drawing. Through the lateral part of our brainstem, ascends. When it gets to the brainstem, above the brainstem, it gets to a place where we have a bunch of nuclei. This bunch of nuclei, so that's what? I mean, I know you can be guessing, you could have gotten the name right now. The thalamus. The thalamus. Actually, in this bunch of nuclei, it goes to a specific nuclei. The ventroposterolateral nuclei, VPL. The ventroposterolateral nuclei. So here comes the question. At what point exactly do we feel pain? Where is the pain? Where is the sensation of pain generated? Do you think pain is generated here in the tissue that was damaged? No. This is the point where we feel pain. The third order neuron that lives. Okay, at this point of the thalamus, the ventroposterolateral nucleus, right? It synapses, and the third order neuron, the third player to get the baton, now takes off from the thalamus. This is the point where pain is felt. Then you mean like, what do you mean like, why do you mean, what do you mean like pain is felt in thalamus? What about all the tracts? What happened to the ascending pathways? You told me the ascending pathways started from the receptors up to this point. And you're telling me now, it is only now that it is in thalamus we are feeling pain. Yeah. Right from the receptor to the thalamus, it has just been what? Electrical signals. It has just been what? Impulses. Your brain could not actually differentiate which one was which. It just said as impulses. Just like when you see an object, your eyes just get what? Signals, electrical signals, impulses. You cannot tell what exactly it is saying, right? Till the message gets to the calcarine sulcus of your occipital lobe, the message is not interpreted as what? Vision. So, same as the thalamus. Till it gets to the thalamus, the message is just what? An electrical signal. When it gets to the thalamus, what? It is now interpreted as what? Pain. And the message is now sent from the thalamus, what? You know, you have the spinothalamic tract. From the thalamus, what? To your what? Cerebral cortex. Wow. I'm quite the best artist in the world. So what? From the thalamus, what? To your cerebral cortex. Right? So from what? The thalamocortical tract. That leads to another question. Another question comes. How does your brain know exactly where it is feeling pain? Like, if I'm feeling pain in my leg, how does my brain know that it is not my hand that is feeling pain? That leads us to another part I'm going to explain now. Now, in your brain, in the cerebral cortex, actually, in our cerebral cortex, we have what? Different parts. We have the frontal lobe, parietal lobe, the occipital lobe, temporal lobe, right? Now, in the temporal lobe, frontal lobe, parietal lobe, and occipital lobe, right? In the parietal lobe, let's say this is the parietal lobe. In the middle, we have what? The central gyrus, right? And in front of it we have the what? The precentral gyrus. If the center is what? The central gyrus. And at the back we have what? The postcentral gyrus. The postcentral gyrus is the part responsible for collecting what? Every single sensation. Every sensory information comes to the what? That this somatosensory comes to what? To your postcentral gyrus. Your precentral. Then you ask, what is your precentral? Your precentral is for motor. That's enough for today's topic. Maybe someone like some other lecture, right? So how does, okay, fine, I agree. How does it know where exactly, Okay, fine, it goes to the postcentral gyrus. How does it know exactly where you feel pain, right? Now this is to one that thing I'm going to talk about. Now in your brain, your whole body, from your head to your toe, is represented on your brain. Let's say let's assume that this is a lateral section of your brain, and this is your postcentral gyrus. We have actually a kind of representation of your whole body. We call it what? The homunculus. You can actually check it out online if you want more. The hand is represented on the upper part of your postcentral gyrus. Your face, this is your face. Then your legs. You kind of placed upside down, something like that, yeah? So this is exactly how your brain knows where exactly you are feeling pain. So if you are feeling pain in your leg, the fibers coming from your lower part of the body goes to the exact same spot on the postcentral gyrus. Let's say this part, let's say this part is your postcentral gyrus, and this part shows your face. So meaning that for me, even if you have pain, what in your thigh, right? It goes to the point where the thigh is represented on the postcentral gyrus, and the fibers are sent there. So when the fibers hit that part represented, that thigh represented on your postcentral gyrus, your brain now knows, oh, there is pain actually going on in the thigh. And then it sends a motor response to cause what? Withdrawal. Because it knows that, your brain knows that if I leave that tissue in that point for long, it's going to get damaged because of what? Thermal stimuli. So then that brings us to almost the end. We're almost done with this lecture. Almost the end of the pain battery. So I'm going to talk about now the pathways of the C fibers, right? Its role. And I'm going to talk about the role of anesthetics in pain, and quickly run through why we use NSAIDs for treatment, and why do we use an anti-inflammatory drug for treatment of pain. And in further videos I might talk about phantom pain and different kind of pain. So guys, we'll see what happens with the C fibers. Actually, the C fibers take similar route, but something happens when it gets to the dorsal horn. When it gets to the dorsal horn of the gray matter of the spinal cord, let's see what happens. So to get a clearer view of what really happens in the spinal cord, I'll try to make a zoom of the spinal cord. Yeah. So from the nociceptors, the C fibers, from peripheral receptors, yeah, the cell bodies in the dorsal root ganglion. So something happens when it gets to the spinal cord. So something happens to the C fiber. Hope it's clear here. So when the central process is a peripheral process, cranial ends receptors, C fibers. When the central process of the C fibers get to the dorsal horn, something happens here. It terminates. It synapses, unlike, remember in the A fiber, in the other fibers, right? They synapsed and they crossed over, right? The second order neuron crossed over. But here in the C fibers, they're going to terminate and synapse in what? In an interneuron. In an interneuron. So this interneuron will give off So that neuron now cross over to the other side and also ascend. Yeah. Actually, this interneuron is located in a place in this dorsal horn known as the substantia gelatinosa. Actually, it's called substantia gelatinosa because it kind of looks like what? It kind of looks like a jelly or something like that. And the dorsal horn is actually made of 5 layers, right? In layer 2 and 3, that's where the substantia gelatinosa is found. So that's why it's called the gelatinous layer. And why am I telling you this? We'll find out. And actually, I forgot to say that pain has this transmission process. The whole perceiving pain. This pain has 5 main processes. You have the first, transduction. Transduction I mentioned earlier is the phase where this mechanical stimuli, like from the touch, is converted to electrical impulses and sent to your spinal cord, right? Yeah. So the next part is what? Transmission, then what? Conduction, then perception, then finally modulation. So when we talk about the modulation of pain in later videos, we will see how important this part is, this gelatinous part is. So let's follow up to see what happens to the C fibers as it goes. Remember I mentioned earlier that pain has what? Emotional part, right? So we'll see why do people actually cry? Why do they feel sad when you feel pain? Is this something that occurs naturally, or there is something that your brain has to do with it? Let's find out. Yeah. So I'll make a smaller diagram of start. Yeah. So this is our pseudounipolar ganglion, peripheral process of the C fibers ending in what? C fibers ending in what? Receptors, this central process going to the spinal cord, going to the dorsal root, where it gives us an interneuron in the substantia gelatinosa, crosses over and ascends upward. So as also passes to the lateral part of the brainstem. Yeah. So something happens when it gets to after going through the lateral part of the brainstem. These C fibers actually give up some minor fibers to places, so some very important places in your brain. The first part is this reticular formation. It sends some fibers to the reticular formation. I remember what the reticular formation is for. Yeah. The reticular formation acts like what? A shot. It's the part that regulates like your sleep, the circadian rhythm and stuff. Yeah, it's regulated by your pineal gland and stuff, yeah. But the reticular formation acts like a shot, the part that kind of controls the amount of information going to the brain. So when you sleep, it kind of shuts down the information going. That's why when you are asleep, you can get an object placed in front of your eyes. Someone can open your eyes and place an object in front of it, but you cannot see anything. Why? Because your reticular formation has kind of stopped every message going to your brain at that particular point. So what does pain do? Pain, these C fibers give off pain information to this reticular formation, which kind of activates the reticular formation. And when this happens, what happens? You cannot sleep. That's why when you have some high amount of pain, you can't sleep. So this is the reason. These fibers, this part of these C fibers giving up to the reticular formation causes you not to sleep. So I've answered the first one. So the next one is, why do we actually feel sad? Why do people cry? Why do girls cry when they feel pain? And why do we feel sad and stuff like that? That's because the C fibers also give off branches to where? Can you remember the part that controls our emotions? The limbic system. Our limbic system is our primitive part of our brain that has to do with our emotions. So these C fibers also give off branches where? To our limbic system. Let me use space here. To our limbic system, limbic cortex. That is why we have mixed feelings. We have pain, we cry, because it activates some certain regions in our limbic system. So these C fibers also give fibers to our cerebral cortex, so the somatosensory cortex, the part that is that is responsible for our pain, our postcentral gyrus. But guess what? they give only few fibers to just few random fibers to the hypocentral gyrus. So this because of these fibers are not enough to get to those particular regions, it just spreads. That's why pain is not actually specific. That's why sometimes you can feel pain. You can feel some achy pain in your legs, but you cannot tell exactly where it is because these C fibers are not really specific. They're just some random fibers to the region. That is to say that if you are having pain in your leg, right, it gives some random fibers to your leg. It's not really specific to the exact point on your leg, right? So that's why you can feel some achy pain, achy toe pain, but you're trying to look for where you're feeling the pain, but you cannot actually look at where you're feeling the pain, right? Yeah. So that's that for the C fibers. And I told you that these C fibers are not myelinated. So they are very slow. They come after the sharp pain. They are very slow. About 0. few meter per second or so, 0.1 meter per second. They are very slow. And what? And their conduction system takes a lot of time. You get? So that's that for that. So guys, we'll see what happens with the C fibers. Actually, the C fibers take similar route, but something happens when it gets to the dorsal horn. When it gets to the dorsal horn of the gray matter of the spinal cord, let's see what happens. So to get a clearer view of what really happens in the spinal cord, I'll try to make a zoom of the spinal cord. Yeah. So from the nociceptors, the C fibers, from peripheral receptors, yeah, the cell bodies in the dorsal root ganglion. So something happens when it gets to the spinal cord. So something happens to the C fiber. Hope it's clear. Yeah. So when the central process is a peripheral process, cranial endings receptors, C fibers. When the central process of the C fibers get to the dorsal horn, something happens here. It terminates. It synapses. Unlike, remember in the A fiber, in the other fibers, right? They synapsed and they crossed over, right? The second order neuron crossed over. But here in the C fibers, they're going to terminate and synapse in what? In an interneuron. In an interneuron. So this interneuron will give off to another neuron that will cross over to the other side and also ascend. Yeah. Actually, this interneuron is located in a place in this dorsal horn known as the substantia gelatinosa. Actually, it's called substantia gelatinosa because it kind of looks like what? It kind of looks like a jelly or something like that. And the dorsal horn is actually made up of 5 layers, right? In layer 2 and 3, that's where the substantia gelatinosa is found. So that's why it's called the gelatinous layer. And why am I telling you this? We'll find out. And actually I forgot to say that pain has this transmission process. The whole perceiving pain. This pain has 5 main processes. You have the first transduction. Transduction I mentioned earlier is the phase where this mechanical stimuli, like from the touch, is converted to what? Electrical impulses and sent to your spinal cord, right? Yeah. So the next part is what? Transmission, then what? Conduction, then perception, then finally modulation. So when we talk about the modulation of pain in later videos, we will see how important this part is, this gelatinous part is. So let's follow up to see what happens to the C fibers as it goes. Remember I mentioned earlier that pain has what? Emotional part, right? So we'll see why do people actually cry? Why do they feel sad when you feel pain? Is it something that occurs naturally or there is something that your brain has to do with it? Let's find out. Yeah. So I'll make a smaller diagram of start. Yeah. So this is our pseudounipolar ganglion, peripheral process of the C fibers ending in what? C fibers ending in what? Receptors, this central process going to the spinal cord. going to the dorsal root, where it gives us an interneuron in the substantia gelatinosa, crosses over and ascends upward. So as also passes to the lateral part of the brainstem, yeah. So something happens when it gets to the, after going through the lateral part of the brainstem. These C fibers actually give up some minor fibers to places, so some very important places in your brain. The first part is the reticular formation. It sends some fibers to the reticular formation. I remember what the reticular formation is for. Yeah. The reticular formation acts like what? A shot. It's the part that regulates like your sleep, the circadian rhythm and stuff. Yeah, it's regulated by your pineal gland and stuff. Yeah. But the reticular formation acts like a shot. The part that kind of controls the amount of information going to the brain. So when you sleep, it kind of shuts down the information going. That's why when you are asleep, you can get an object placed in front of your eyes. Someone can open your eyes and place an object in front of it, but you cannot see anything. Why? Because your reticular formation has kind of stopped every message going to your brain at that particular point. So what does pain do? Pain, these C fibers give off pain information to this reticular formation, which kind of what? Activates the reticular formation. And when this happens, what happens? You cannot sleep. That's why when you have some high amount of pain, you can't sleep. So this is the reason. These fibers, this part of these C fibers giving up to the reticular formation causes you what? Not to sleep. So I've answered the first one. So the next one is, why do we actually feel sad? Why do people cry? Why do girls cry when they feel pain? And why do we feel sad and stuff like that? That's because the C fibers also give up what? Branches to where? Can you remember the part that controls our emotions? The limbic system. Our limbic system is what? Our primitive part of our brain that is constant, that has to do with what? Our emotions. So these C fibers also give what? Give up branches where? To our limbic system. Let me give space here. To our what? Limbic system, limbic cortex. That is why what we have mixed feelings. We have pain, we cry because it activates some certain regions in our limbic system. So these C fibers also give what? Fibers to our cerebral cortex, so the somatosensory cortex, the part that is that is responsible for what? Our pain, our postcentral gyrus. But guess what? They give only few fibers to just few random fibers to the postcentral gyrus. So this because of these fibers are not enough to get to those particular regions, it just spreads. That's why pain is not actually specific. That's why sometimes you can feel pain. You can feel some achy pain in your legs, but you cannot tell exactly where it is because these C fibers are not really specific. They're just some random fibers to the region. That is to say that if you are having pain in your leg, right, it gives some random fibers to your leg. It's not really specific to the exact point on your leg, right? So that's why you can feel some achy pain, achy dull pain, but you're trying to look for where you're feeling the pain, but you cannot actually look at where you're feeling the pain, right? Yeah. So that's that for the C fibers. And I told you that these C fibers are not myelinated. So they are very slow. They come after the sharp pain. They are very slow. About 0. few meter per second or so, 0.1 meter per second. They are very slow. And what? And their conduction system takes a lot of time. You get? So that's that for that. So that leads to another question. How does your brain know when you are having a severe pain and a minor pain? How does it differentiate when you have a little pain, like you call it, or a more severe pain? Does it mean that when there is a severe pain, it sends a strong impulse to the brain, to the postcentral gyrus? When there is less pain, it sends it sends a weak signal to the postcentral gyrus? No. Remember I told you earlier that the brain works with what? The neurons will work with what? All or none law. If the stimulus is not strong enough to kick an action potential, it is not generated at all. It is either generated or not. Meaning that they have all similar signals, no matter what kind of pain it is. Whether it is severe pain or less severe pain, the same strength remains the same. You get? It is the strength does not change. So the question now comes like, how then does the brain know exactly how to differentiate between what? And a chronic pain and a mild pain, a soft pain that is not really that painful. That comes to what they call frequency coding. Your brain now. So what happens is that when you're feeling a severe pain, when the pain gets out of hand, right? The since you cannot actually the site of damage cannot actually generate a stronger or weaker impulse, it can increase the frequency of excitation. So it increases the amount of information it sends to the postcentral gyrus, meaning that if for a stronger pain, like you call it, it increases the amount of fibers it sends per second to the brain. So if the pain is mild, it says like few fibers hit the postcentral gyrus. But if pain is a strong pain, what? A lot of fibers hit this postcentral gyrus. So when these fibers keep hitting this postcentral gyrus, the brain interprets it as what? A chronic strong pain, like you call it. And that's how it knows what exactly what kind of pain it is, if it is going to be a strong pain or a weak pain. So yeah, that's it for that. So that brings to, and that finally, so let me quickly answer this question, like, how does your is there anything that can cause hyperalgesia? What happens? What really happens when you all of a sudden have some increased sensitivity to pain? And why is it that when you have some little inflammation in your skin, why is it the pain kind of increases? Well, like you find out that, like, let's say you have some balls in some places, like in Whitlow, right? You find out that the pain is really so severe. Why is it like that? That brings it up. And that will also lead us to the answers of why you can actually use non-steroidal anti-inflammatory drugs to treat pain. Yeah. You find out that in inflammation, we find out that there are some inflammatory mediators that are released during inflammation, right? Yeah. And these inflammatory mediators have the ability to what? Increase the sensitivity of the nociceptor to pain. An example of an inflammatory mediator is what? Prostaglandin and substance P. Prostaglandins and substance P has the ability to what? Increase the sensitivity of the nociceptor to pain. That's why when there's inflammation, you kind of have this increased sensitivity to pain. You have increased pain. Why? And how do they do this? Prostaglandins have the ability to what? To lower the pain threshold. I told you, for example, like if the threshold for pain was at minus 90 millivolts, right? At this point, an action potential is generated. I told you that in all or none law, if can you really see it? Okay, let me quickly feel it. Yeah. So I told you if the pain threshold, let's say it's at minus 90 millivolts, at this point an action potential is generated, right? So meaning that if the response coming in does not hit this threshold, an action potential will not be generated and you won't feel pain, right? So I told you that any sub-threshold stimulus can only cause what? A local response till it hits the threshold of excitation of this neuron, or this pain neuron. Then what? An action potential is sent. A depolarization followed by repolarization and hyperpolarization, and finally back to depolarization. Yeah. So what happens is that prostaglandins, they lower the threshold for excitation of this neuron. So if the normal threshold for this pain neuron is minus 90 millivolts, it reduces it to about what? Let's say minus 60 millivolts. So what? So now this response, this pain stimulus does not have to do much to get an action potential. This local response, once it hits minus 60 millivolts, an action potential is sent. You get? So it does not have to get to minus 90 millivolts for an action potential to be sent and a pain stimulus generated, right? So it is now, the threshold for excitation is now much lower and makes it what? Easier for you to feel pain. So that's what this prostaglandins and substance P did. And also bradykinins. That's why if you inject bradykinins in people that have pain, they don't really like it at all. it's really painful, right? Because they lower the what? They excited the pain threshold, right? So it makes it easier for you to feel pain. So now what happens when if you've seen during surgeries, right? They give some, let's say in case you want to do it like a local surgery, like to cut open or something, like I said, weight loss, for example, when you want to cut open and drain the weight loss, they give some kind of lidocaine, right? A local anesthetic. How do these local anesthetics work? Lidocaine, for example. So how exactly does lidocaine work? I told you earlier that what? There's sodium ions, like aluminum ions, that have the ability to what? Alter the what? Polarity of the cell. That the reasons why you can what? Have this action potential is developed, because when sodium, the influx of sodium, positive ions gets much, it hits the threshold and what? Depolarization occurs. So meaning that if sodium influx is inhibited, what will happen? There will be no generation of what? An action potential. And there is no generation of action potential, what will happen? The nerves, the transduction will not occur. Those mechanical stimulus will not be converted to what? Electrical stimulus, and it will not get what? To your what? Dorsal horn of your spinal cord, and it will not be sent to your brain. So where does lidocaine come in? Guess what lidocaine does? Lidocaine blocks these sodium channels. So meaning that you might get stabbed in that place, right? The local response might come in, but this response is actually supposed to stimulate the opening of sodium channels and influx of sodium ions into the cell. But because these channels, these sodium channels, sodium pumps, these sodium ion pump channels has been blocked by lidocaine, what? It means that what? Sodium ions will not come inside the cell, and if they don't come inside the cell, what will happen? No depolarization will occur. Action potential will not be generated, meaning that what? Pain would not be felt. And that is how exactly your local anesthetic they give you when your surgeon, when your dentist gives you that local anesthetic in your teeth and stuff. That's exactly how it works. It blocks the sodium pumps. So what? Depolarization does not occur. And if the depolarization does not occur, what? The pain sensation is not felt. So hopefully in later videos we'll be seeing about how pain is modulated, the importance of this substantia gelatinosa, the interneurons, right? The interneuron of the C fibers, how our brain helps us when we feel pain, how it helps us to control pain. So keep watching out for more videos from the Webzmedlectures who bring simplicity at its peak, right? Yeah. So see you next time, and God bless.